Okay, I won't spend too much time on this slide. We've gone through it. So not enough ADH secretion by the posterior pituitary leads to diabetes insipidus. And again, this can be from anything that's injured the hypothalamus or the pituitary gland, right? This is produced in the hypothalamus and it's stored in the pituitary gland. So any kind of a surgery or head injury can lead to diabetes insipidus. And it's the condition where water is not reabsorbed due to lack of ADH, and you can make tremendous amounts of urine, right? Many liters of urine per day. So that's going to lead to dehydration unless the person can continually drink to keep up with the losses in the urine. Okay? The urine is dilute, typically no matter how much they drink. The urine is dilute because ADH isn't able to concentrate the urine since it's not there. Okay? And what results is hypernatremia from a concentrated plasma and dehydration because of all the water losses in the urine. Okay, let's just go through this slide quickly. So diabetes insipidus, so lack of ADH, how can it be taken care of? Well, it can be treated with ADH replacement, which is one called DDAVP or vasopressin. They're both ADH, okay? DDAVP comes as a nasal spray, as I mentioned before, for children that are still bedwetting as they get older. Okay, let's look at the symptoms of diabetes insipidus. I think they'll make sense. We've gone through this already. So significant urine loss because you can't reabsorb the fluid in the kidneys due to lack of ADH. So up to 20 liters of urine per day. That's a lot of urine. Okay, reduced specific gravity in the urine. Reduced osmolarity of the urine. Hypovolemia. So your circulating plasma volume is reduced because of all the water you're losing. You're going to be hypernatremic, right? High sodium. That's going to stimulate thirst, right? It's going to make you want to drink. And of course, the dehydration is going to make you want to drink as well. Tachycardia. Because the heart is sensing all this fluid loss, it wants to maintain cardiac output. And lastly, because of all the fluid loss, decreased blood pressure. Okay? So really, in terms of nursing considerations or care, well, monitoring fluid input and output. How much urine is this person actually losing per day? Replacement of fluids, right? So if someone's losing liters and liters of urine a day, they're going to become dehydrated unless we replace their urine. Neurological status. Why? Hypernatremia, right? So high sodium typically gives neurological symptoms. Vital signs. Why? Because of the dehydration, the potential for hypotension, and tachycardia. And assessment of fluid status, say for example by examining the mucous membranes. Okay, so all of these signs and symptoms and what we would check for make sense once you know what the underlying problem is. Okay, I'm going to skip this slide. I'm going to leave it to you. Look at the different bullet points here and make sure you understand why each one is occurring in diabetes insipidus and SIADH. I really think it'll make sense now. Okay, so let's have a look at this question. Fatigue, heat intolerance, increased heart rate, and weight loss are signs and symptoms of. Okay, anemia. Well, anemia is low hemoglobin or low circulating red blood cells. Same thing. Sure, that's going to cause you to be fatigued. It's not going to make you heat intolerant. It could definitely make your heart rate increase, but it's not going to lead to weight loss. Okay, so A is out. Hypothyroidism. Well, hypothyroidism can definitely cause fatigue. It usually makes you intolerant to cold because there's decreased metabolism, right? So, heat intolerance is not a symptom of hypothyroidism. Increased heart rate, that's not a symptom of hypothyroidism. It's usually bradycardia because there's decreased metabolism. And weight loss, no, there's usually increased weight with hypothyroidism. Again, due to reduced the metabolic functions in the body. Graves' disease, okay, that's hyperthyroidism. That's the autoimmune disease causing hyperthyroidism. Yes, it can cause fatigue, which is a bit strange because I really associate that with hypothyroidism. But Graves' disease can lead to fatigue because of excessive hypermetabolism in the body. Heat intolerance, absolutely. There's so much metabolic processes taking place that are being stimulated by the excessive T4 in the blood that you're heat intolerant. Increased heart rate, absolutely. Graves' disease not only increases heart rate, it can cause atrial fibrillation. And weight loss, for sure, because of all the energy that's being used with hyperthyroidism. So Graves' disease is going to be the answer. C. Diabetes insipidus is a fluid and electrolyte issue, right? Where you're losing tremendous amounts of water into the urine and you're getting concentrated plasma with hypernatremia. So, could you be fatigued? Yeah, it's possible. Heat intolerance? No. Would you have an increased heart rate with diabetes insipidus? Sure, you'd be dehydrated, you'd be tachycardic. Could you have weight loss with diabetes insipidus? Absolutely. You're losing liters and liters of water per day. Okay? So you wouldn't have the heat intolerance. So the only one that really fits this one is Graves' disease. Okay, so next question. Fatigue, heat intolerance, increased heart rate, weight loss, all indicate hyperthyroidism. What mechanism is the cause? Okay, so renal tubules are retaining water. No, that's going to be from ADH, right? That's going to be from SIADH. Epinephrine is being released. No, that's the adrenal medulla. And if there was excessive epinephrine release from the adrenal medulla, that would be pheochromocytoma. Hypernatremia is just a state, it's just a condition. So it's not really a mechanism. So I'm not going to choose that one because that's just a stating the fact that sodium is elevated. So no mechanism there. Cellular metabolism is increased. Yes. So hyperthyroidism leads to heat intolerance, increased heart rate, and weight loss because cellular metabolism is increased by excessive T4 levels in the bloodstream. Okay, so let's move on to diabetes mellitus. And we're going to talk about two types, right? There's going to be type 1 diabetes and type 2 diabetes. So what are the processes that are involved in the two types of diabetes? Well, in type 1 diabetes, there's inadequate insulin production by the pancreas, and that is an autoimmune disease. It is far less common than type 2 diabetes, which is the inability of the cells around the whole body to use the insulin that's circulating in the bloodstream. Okay, so an insulin resistance is typical for type 2 diabetes. We'll talk about that again. Okay, and so what happens in either one of these diabetic conditions? Well, elevated blood glucose. So in type 1 diabetes, where your pancreas is not producing any insulin because of an autoimmune destruction of the beta cells in the pancreas, well, now the circulating sugar has nowhere to go in terms of being absorbed into cells, since it needs insulin to do that. So you're going to have a high serum glucose. Okay? What about type 2 diabetes? Well, the pancreas initially is just working fine. It can produce insulin, no problem. The problem is that there's cellular resistance to the insulin, meaning that the cells aren't being affected as much by the insulin that's attaching to the receptors. And because the insulin isn't able to affect the cells the same way, then glucose can't get into the cells, also leading to hyperglycemia. Okay? So now there's definitely a genetic tendency in families towards both type 1 diabetes, which is an autoimmune condition, and also type 2 diabetes, which is not an autoimmune deficiency, an autoimmune disease. Okay, that's an insulin resistance problem that we'll talk about. Can there be environmental triggers that lead to type 1 diabetes as well? Absolutely. Okay, we don't know all the environmental triggers, but there's definitely a genetic component to type 1 diabetes and environmental factors that lead to this autoimmune destruction of the beta cells in the pancreas. Okay, so keep them separate. Type 1 diabetes, pancreatic failure to produce insulin. Type 2 diabetes, insulin resistance at the cellular level all over the body. Okay? In fact, in type 2 diabetes, you often have high levels of insulin circulating in the bloodstream because the pancreas is detecting this higher and higher glucose level, and it produces more and more insulin to try and get the glucose into the cells. But because of the cellular resistance, the glucose can't get into the cells. Okay? So it's an insulin resistance problem. Okay, so we'll finish off the slide at the bottom. What are the types of diabetes? Type 1 diabetes, yep, insulin deficiency from the pancreas, autoimmune disease. Type 2 diabetes, by far more common than type 1 diabetes. The cells in the body are not sensitive to insulin for a variety of reasons. The most common one being obesity. Okay? And lastly, there's gestational diabetes. And this will kind of make sense. What happens in pregnancy? Well, you gain weight, right? You gain weight as the fetus grows, and that leads to insulin insensitivity. So the cells become resistant to insulin, which is very similar to type 2 diabetes. And that's why some women that are pregnant and develop gestational diabetes, it's kind of an indicator. It was a bit of a stress test to their body to see if they can become diabetic with weight gain. And later on in life, they develop type 2 diabetes more commonly. Okay? Okay, so let's just talk about normal insulin secretion. Okay, so insulin is secreted by the beta cells in what are called the islets of Langerhans within the pancreas. And what's the function of insulin? Well, it's to get the glucose that's in the serum into cells around the body to use as energy, right? So insulin will also go to the liver and say, you know what, I have too much circulating glucose. I want to turns some of this glucose into glycogen for storage. Okay? So it lowers overall blood glucose by allowing glucose into cells around the body. Okay? But remember, not only does it do that, it signals the liver and the fat cells to take in glucose from the blood. And it will store, well, in particular, the liver will store glucose as glycogen for a rainy day where it needs to convert glycogen back to glucose to use as energy. So glycogen is our storage of glucose in our liver. Okay? So basal rate insulin. So we always have a bit of insulin being secreted by our pancreas. Okay, just a little bit all the time, 24 hours a day, and it's regulating glucose levels in the bloodstream. Okay, it's allowing glucose into cells. It's telling the liver, okay, you can store a bit of glucose into glycogen, just tiny amounts of insulin. What about bolus insulin? Well, if you eat a meal, suddenly your serum glucose is going to go up. That's going to stimulate the pancreas to release insulin to quickly get the glucose into cells stored in the liver as glycogen. Okay, so that's the overall function of insulin. Okay, what are some hormones that can counter insulin? They can actually force glucose out of the liver and turn glycogen to glucose. Well, glucagon. So glucagon is also made in the pancreas, and it's the counter hormone to insulin. So if glucose levels get too low in the bloodstream, the pancreas can release glucagon to force conversion of glycogen to glucose to bring the glucose levels back up in the bloodstream. Okay? Epinephrine. So epinephrine is part of the sympathetic nervous system. Well, epinephrine can stimulate the liver to break down glycogen to glucose because there's some kind of stress happening. There's some kind of emergency. So I better release more glucose into the bloodstream. So epinephrine can do it. Cortisol. Well, cortisol is a stress hormone released by the adrenal cortex. So if cortisol levels go up from the adrenal cortex because of stress or an illness, that's going to cause glycogen to convert to glucose. So the body always makes sure it has enough glucose in the bloodstream. Growth hormone. Well, growth hormone is an anabolic hormone, right? It's building all the time. It's building proteins, it's building tissue, and it wants to make sure that there's enough glucose in the bloodstream, okay? So, for example, if I take cortisol every day, day in, day out, in the form of prednisone, well, I have a risk of developing diabetes because the cortisol is releasing glucose from the liver. Cortisol will also make me gain a lot of weight, and that will lead to insulin resistance at the cells. So it will lead to type 2 diabetes. Okay? So these are just counter-regulatory hormones that exist in the body because the body never wants to have low sugars, because that would mean the brain is going to receive low sugars, and it never wants that to happen. So all of these systems are in place to make sure that you don't become hypoglycemic. So glucagon released by the pancreas very quickly if there's hypoglycemia. And by the way, ambulances use glucagon injections, or emergency rooms use glucagon injections as an intramuscular shot to raise serum glucose very quickly. Epinephrine, sympathetic nervous system, let's get the sugar higher in the bloodstream. Cortisol, a stress hormone from the adrenal gland, I need more glucose in the bloodstream. Okay? So always there's these protections to make sure that hypoglycemia never happens. Okay? So under normal conditions, serum glucose is typically between 70 and 120. Okay? If it goes too low, well, those counter-regulatory hormones are going to kick in. Glucagon, epinephrine, cortisol. Okay? If it goes too high, well, insulin will be secreted to have the glucose go into cells and also stimulate the liver to convert glucose in the serum to glycogen in the liver as storage. Okay, so this will be a bit of a repetition. If you're comfortable with the above slide, you can skip this one. So increased serum glucose stimulates insulin secretion by the beta cells in the pancreas. And of course, the insulin will go directly into the bloodstream, and insulin will bind to cell receptors around the body, right? Muscle cells, fat cells, liver cells, all over the body, okay? And it opens channels to allow glucose to enter the body. By the way, when insulin is allowing glucose to enter cells around the body, potassium goes with it. Don't forget that, because that's going to be one of the treatments that we use for hyperkalemia, giving insulin to force glucose, or to force potassium into cells. Okay, so just remember that little bit. Now insulin will also signal the liver to say, you know what, store some of this glucose. I have too much of it. Make it into glycogen, please. Okay, so and we have quite a few days of glycogen storage. So if you didn't eat any glucose, or actually if you didn't eat anything except water, you have quite a few days of glycogen storage that can be released into glucose. Okay, so it's a safety mechanism for the body to make sure that you don't run out of glucose in your blood. Okay, so really the goal of insulin is to control blood glucose levels, stimulate liver cells to store it into glycogen, stimulate fat cells to take in some glucose that they can then convert into lipids, into fats within fat cells. Okay, so insulin is saying, I need to get rid of all this sugar in the bloodstream. What can I do with it? Well, I can give it to all the cells for energy, I can store it in the liver, or I can store it in fat cells. Okay, so let's look at this normal insulin secretion by the pancreas over 24 hours. So let's start at midnight, where there's just a basal secretion of insulin, tiny amount, right? And that's because the liver is constantly releasing a bit of glucose if the body needs it. And then as the glucose leaves the liver, insulin gets secreted to allow it into cells to use as energy, right? So there's always a bit of insulin being secreted. Okay, let's look at breakfast now. So breakfast time comes, you eat something, and suddenly there's an insulin spike. That's to allow the body to clear the glucose from the bloodstream into cells, into liver, into fat cells, and then the insulin levels come back down, only to repeat themselves at lunchtime, okay? And then at dinner time, right? So we get insulin spikes with meals. So if you're having really sugary meals that are high in carbohydrates and high in sugars, you're going to get very large insulin spikes. And every time you have an insulin spike, you store more glucose in the liver, and you store more glucose in your fat cells, okay, as lipids. So if people think that they can lose weight by not eating fats, but eating carbohydrates, it's never going to happen because the body just converts the glucose in fat cells into fatty acids, okay? So that wouldn't be a great weight loss program. So this is the typical spikes of insulin throughout the day. And this will make more sense when you're understanding how insulin is given to a type 1 diabetic, right? They typically get a shot of short-acting insulin at breakfast, lunch, and dinner, okay? That's to mimic what's happening in a normal body since their pancreas isn't working any longer. And often they get a long-acting insulin that can pretend to be the same as the basal insulin that was constantly being released in their body naturally. Okay, I won't spend too much time on this slide. This is showing you glucose in the bloodstream, insulin in the bloodstream, and then insulin receptors on all types of cells throughout your body. So you can think of the muscle cells that need glucose for energy. You can think of brain cells that use glucose for energy, really anywhere in the body, right? And insulin activates or binds to the receptor. It opens the protein channel and allows glucose into the cell. Okay, that's the normal function of insulin. Now, just imagine on this slide if you're lacking insulin. Well, all of that glucose has nowhere to go, right? It's just in the bloodstream circulating at a very high level. And when you have tremendous amounts of glucose, it's going to leak out through the kidneys, causing polyuria because water's going to go with it. So they're going to be urinating a lot. That's going to make them thirsty, right? Because they're getting dehydrated. So now they're drinking a lot, okay? They're hungry. Polyphagia is I'm hungry. So why are they eating a lot? Well, they're losing energy in their urine. So the body is saying, well, you're losing energy in your urine, you're losing fluids in your urine, so I want you to drink more because you're going to get dehydrated, and I want you to eat more because you're losing energy in the urine. Okay, so those are typical symptoms of diabetes. Polyuria, polydipsia, meaning increased thirst and increased drinking, and polyphagia, increased appetite and increase in eating. Okay, so that's what happens is if insulin is missing. What if insulin isn't missing? There's lots of insulin around, but the receptors are just ignoring it. So that's called insulin resistance or insulin receptor resistance. Well, the same thing happens, right? You get a whole bunch of glucose in your urine or in your bloodstream, and it's going to leak out through the kidneys. You're going to get polyuria. You're going to be thirsty, so polydipsia. You're going to be hungry, polyphagia. But there's some really important things that are going to be very different between type 1 diabetes and type 2 diabetes, and we'll talk about those. But the overall common symptoms of urinating a lot, drinking a lot, eating more, those are common to both diabetes.